Hello, everyone. I know you've just taken a pre-assessment quiz on insulin and diabetes, but this lecture will be focusing more about the most common types of insulin. So the American Association of Diabetes recognizes four clinical classifications of diabetes: type 1 and type 2, gestational diabetes, and diabetes caused by genetic defects or medications. However, in this lecture, I will only be focusing on type 1 and type 2 diabetes. So in type 1 diabetes, this is a chronic autoimmune disease that can sometimes be genetically inherited, causing the body to stop producing insulin, which is a hormone secreted by beta cells from the pancreas necessary for the uptake of glucose from the bloodstream and into the body cells for energy. When we eat, carbohydrates are broken down into glucose. So without insulin, the body's glucose level will simply increase, which will lead to life-threatening ketoacidosis. However, in type 2 diabetes, this is also a chronic condition which is acquired due to the body's inability to use insulin effectively, called insulin resistance, or there may be a lack of sufficient insulin secretion. A combination of factors, including lack of physical activity, being overweight, genetic predisposition, age over 65 years of age, and poor diet, can all contribute to the incidence of type 2 diabetes. So let's look at some of the differences between type 1 and type 2 diabetes. Type 1 diabetics need exogenous insulin administration that must be given subcutaneously to replace the absence of insulin secretion that the body's pancreas no longer produces. Insulin must be given to control hyperglycemia, avoid ketoacidosis, and maintain hemoglobin A1C. So those with type 2 diabetes can use a combination of diet, exercise, oral medication, and or insulin injections to control their blood glucose. So the key here is to perform blood glucose checks regularly before meals, at bedtime, when sick, or signs and symptoms of hypo or hyperglycemia develop. So let's quickly review the normal physiology of insulin in our bodies. So constant release of beta cell secretion maintains low basal levels of circulating insulin, which prevents the breakdown of fat, the breakdown of protein, and the breakdown of glycogen. So after we start eating, a burst of insulin secretion occurs as a response to an increase in circulating glucose and amino acids, which can last up to 15 minutes. This is then followed by a postprandial secretion of insulin to regulate glucose levels in the body. So when our bodies do not do this naturally, sometimes insulin therapy may be required. So according to the 2017 National Diabetes Statistics Report from the Centers for Disease Control and Prevention, 30.3 million Americans have this disease, and yet almost 1 in 4 people with diabetes are undiagnosed. Type 1 is more commonly diagnosed in children and teens and can make up about 5 to 10% of all diabetes cases, compared with type 2, which accounts for 90 to 95% of all diagnosed cases. So let's look at the three main types of insulin. These include fast-acting, intermediate-acting, and long-acting insulin. So in fast-acting insulin, insulin aspart, lispro, or glulisine work quickly mimicking the mealtime release of insulin and control postprandial glucose. The onset of action is less than 15 minutes with a peak effect in 1 to 2 hours and a duration of action of 4 to 6 hours. While intermediate-acting insulin, such as NPH, is used to control glucose levels overnight while fasting and between meals. This is the only type of insulin that has a cloudy appearance. The onset of action is 1 to 2 hours with a peak effect of 4 to 6 hours and a duration of action of more than 12 hours. Long-acting insulins such as glargine or detamir work slowly over an extended period of time with minimal to no peak effect to control glucose levels at bedtime and between meals. The onset effect is 1.5 to 2 hours, which then plateaus in the next few hours and has a flat duration of 12 to 24 hours for insulin detamere and glargine, respectively. So I've included a table of insulin action, including the three most common types of insulin that we've discussed. It also has their onset, peak, and duration times. I do expect you all to memorize this chart. So, as nurses, we must be aware of the modes of insulin administration. So, insulin can be administered using one of the following methods: a vial and syringe, an insulin pen, or an insulin pump. In the United States, these methods of administration only come in one form of concentration, which is 100 units of insulin per 1 milliliter of volume, or you might see it written as U100. So there are definitely some safety concerns with insulin. The most common adverse reaction to insulin is hypoglycemia, which in children and adults is considered a blood glucose level less than 70 milligrams per deciliter, which can be very dangerous and must be treated and corrected. All patients on insulin should be taught how to do this. Weight gain is another a possibility. Local injection site reactions can occur, such as the development of scar tissue, and the importance of rotating injection sites can also help avoid lipodystrophy, which is a maldistribution of fat tissue in our bodies. So, as nurses, we should be aware of insulin dosing. So, I've included some calculations of how to figure out total daily insulin requirements and how to estimate the dose for a long standing insulin. So, as patients get more familiar with insulin administration, their endocrinologists will often teach them how to carb count. So, carb counting is a way of covering your mealtime carbohydrates. So, for example, you would take the total grams of carbohydrates in a meal and divide it by the grams of carbohydrate disposed by 1 unit of insulin. So, in the hospital setting, we would normally say that about 15 grams of carbohydrates is equivalent to 1 unit of insulin. So, for example, if a patient was to have about 60 grams of carbohydrates in a meal, we would then divide that by 15, and that would tell us the amount of units of insulin that would cover the patient for that meal. I've also included how to calculate high blood sugar correction and how to figure that out as well. So as you can see, insulin can be very expensive. So for example, Humalog is roughly $325 for a 10 milliliter vial, while Lispro is priced around $200 per vial, and the generic of Humalog is priced at about $170 for a 10 milliliter vial. And of course, you have to add the price of syringes to that. A box, for example, of insulin pens, which is even more expensive, for Humalog, it can cost over $600 for a box of 5 insulin pens. While its generic can run over $300, the cost of Lispro, for example, can vary but runs about $150 per 5 3 milliliter pre-filled insulin pens. So, in conclusion, when insulin is used appropriately and at the right dosages, the expected outcome is that adequate management will lead to control of blood glucose. Our goal must always be to help reduce the complications of having diabetes, which can lead to blindness, neuropathy, slowed wound healing, limb amputation, nephropathy, and even cardiovascular disease. So it's really important that we teach our patients to be compliant with their medication regimen and to check their blood glucose on a regular basis and to continue to always follow up with their endocrinologist. So these are my references, and I hope you've enjoyed this presentation.